And I think it would be a mistake not to use the resource. So if you come see me after the first exam, and you say, okay, you know, I'm trying to figure out if there's something else I can do to improve the way my exam scores are in this class, I'm going to go through some of the standard things. So, well, this is the first time I've seen you in my office hours, so I'm going to suggest you come see me more so that I can ask you questions about the material. And then I'm also going to ask you, how frequently are you going to SI? And if you tell me, which is very normal, well, I have a full-time job and none of the SI times work for me. Say, okay, well, but that's something else that you can do in order to be successful in this class. And if your full-time job is getting in the way, maybe you need to back off your hours. Okay? They're tough things for me to say, but it's kind of truth. I mean, if you're overcommitted and you're not able to put in the time for this class, you can't expect to do all that well. All right? So I will try my best to help come up with some ideas, but those are some really great places to start, is understanding if I can't go to any of these SI times, right, that's like, what, 9-10 hours of SI a week? If you can't squeeze in an hour out of 10 options in a week to study for this particular class, with someone who's taken the class and got an A and knows my style and would be your next best resource to say what he thinks to be on the exam, and you can't find an hour to go to an SI session, I'm going to say, do you really have your priorities set correctly for you to be able to do as well as you want to be able to do in this class? Okay? All right, so I do want to encourage you to SI, to use the SI. I also want to encourage you to form study groups. And we're going to go ahead and get started. I have no idea why this slide isn't here. My kids think it's super cute, so they say you should use the slide because there's like, you know, it's kind of funny. There's a mouse and a teddy bear. It's like, all right, fine. So we'll put it in there. So there you go, kids. It's in the lecture. What I want you to do is turn to your neighbor, and I want one of you to define pathology and the other one to define epidemiology. All right, who's got some ideas? An A person. Who would like to give us some ideas of what pathology is? What is pathology? Study of diseases. Do you have something else?
The cause and effect of a disease.
The cause and effect of a disease. Okay. Anything else?
Naming the diseases.
Naming the diseases. Okay. It translates literally as the study of suffering. That's what we're going to do this semester. What do you think of that? Okay, kind of cool. So, the study of a disease. What we would call it, classifying the disease, the name of it. Okay, cause and effect. How about epidemiology? What's that?
The study of trends and causes of disease in society.
Okay, so looking at trend analysis, maybe how diseases migrate, where they show up, how they grow, how they distribute across a certain continent. Do you have something else in the back?
Just to add on that, just the possible containment or stopping of whatever occurs.
Containing the disease. Okay, so understanding how you would intervene so that you prevented the spread from crossing. So it's really looking at factors in illnesses in populations. Okay, so this semester we're really going to focus really on pathology. We'll put into that maybe some elements of epidemiology, but that's really a totally different discipline. Okay? So starting out in the semester, I wanted to kind of compare and contrast how they differ. And I also want to get some feedback from you. Why don't you guys go ahead and write down 5 of your most favorite diseases. They don't have to be ones that you've had, okay? They just be ones you've heard of. Okay, so we're not going to judge. People shout out certain things, and we're not going to change seats. So as you're writing this down, I want to define disease. The term disease broadly refers to any condition that impairs normal function. Commonly, we use it to describe infectious diseases, which are usually clinically evident, and they result in a pathogenic infection. This will include things like viruses, bacteria, fungi, protozoa, multicellular organisms, aberrant proteins, such as prions. We'll look at prions in our nervous system. And this clinically evident impairment will lead to abnormal functionality of the tissue. That is, by definition, what a disease is. So in contrast, an illness or a sickness is usually the symptoms of a disease. Okay, and the underlying issue is the disease itself, and the symptoms or the clinical manifestations might be a specific type of illness, like a cough. Okay, but the disease is a respiratory infection. Make sense? Okay, so what are some examples that you guys have? Yes. I'm sorry, I'm pointing at you.
Necrotizing fasciitis.
Necrotizing what?
Fasciitis.
Fasciitis. Okay. We won't cover that one this semester. Alzheimer's, we'll cover that. Acromegaly, we'll cover that.
Meningitis.
Meningitis, we'll cover that. Heart disease, we'll cover that.
Malaria.
Malaria, we won't cover that.
Lyme.
Lyme disease, we won't get there.
Type 1 diabetes.
Type 1 diabetes, we'll get there.
Scoliosis.
Scoliosis, yes, we'll cover that a little bit.
Parkinson's.
Parkinson's, we'll cover that.
Pneumonia.
Pneumonia, we'll cover that.
Multiple sclerosis.
MS, we'll cover that.
Lupus.
Lupus, we'll cover that.
Friedreich's ataxia.
No, we won't cover that. Anything else? What are some more exotic ones? We're covering, usually you guys come up with all these really exotic ones, and we don't cover them. Tetanus, well, we won't cover that. Cancer, we will cover that.
Giardia.
Giardia, we won't cover that. Now we're getting somewhere.
Motor neuron disease.
Motor neuron disease, no, we won't get there. Maybe a little bit, touch on it. Yes?
Ph.D.
No, we won't get there. Giddy worm, won't do that. Is there a hand over here? Okay, so what you can see is, this is a general pathology class. This is an introductory course on diseases, and we're not going to cover every single one of the diseases that you just mentioned, right? So the idea is the syllabus is already set, so you can look through the syllabus and you can kind of see what systems we are going to cover. And we're usually going to cover a handful of diseases that are either the most prevalent in that particular system, or they're the ones that seem to be most relevant with respect to an introductory phase. Okay? The idea is to get you exposure to these different diseases, and not necessarily trying to be overly comprehensive on every single one. Right? So next thing that I want you to do is I want you to see if you can identify on your list the primary organ system that's affected by the disease that you wrote down. So you should list, ideally, 5 unique organ systems. So this is coming out of 201 and 202. And it's sort of kind of revving up your brain to see if you can recall some of these things. We'll write down the organ system for all of them. You can. It's like heart disease, it's cardiovascular, right? If there's more than one system, write down everything you can think of. I'll explain why here in a second. How'd you do? Were you able to fill in all of them? No? How'd you do? So your homework that I want you to do is I want you to look at that list and I want you to fill in them all. You should be able to identify. If you came up with a disease, it was on the top of your head, you should be able to identify, was it part of the urinary system, the nervous system, cardiovascular system? Okay? Or is it multiple systems, depending upon where it's targeting, like cancer, for example. Maybe it's the digestive system. Okay? Maybe it's the integument, skin, because it's skin cancer. So it may depend. You might have to further define your disease. But just practice. This will help you recall what you learned in 201 and 202. Now here's the other thing. So who had multiple sclerosis? Who had that? Okay, MS. So let's use that as an example. So what are the organ systems that MS would affect? Nervous system. Anything else? Muscular system. And what would be some of the signs of MS? Let's say it's late stage MS. Some of you are like, I have no idea what you're talking about. Okay, we'll get there. But let's just play it out. Multiple sclerosis is a disease that targets, an autoimmune disease, and it targets the myelin wrapping around the neuron. You remember back to 201? You actually should have covered it in 201. Okay? If you took it from me, you absolutely did cover it. It was actually 2 slides that we talked about specifically. But MS targets the myelin, and it degrades the myelin as you attack it because your body thinks that it's foreign. So what that does, what do you think that results in if you break down the myelin around a neuron? Less efficient what? Neuron signals, otherwise known as? Action. Potential. Very good. You're like, it's there, right? No, maybe it's that side. Right? Less efficient action potentials because do you slow down or increase the speed of conduction?
Slow down.
You slow it down if you lose the myelin. What's the result at the level of the muscle? What's that?
Loss of motor function.
Loss of motor function. Okay? So if you had a patient, the reason we're doing this, if you had a patient that was presenting with motor compromised results or elements of motor function that look compromised, and their gait or their walking behavior was abnormal or awkward, right? And they were of a certain age, and there were certain, predisposition in their family, you may actually think we should probably look at this. Okay? So knowing the organ system is a great tool for you to be able to compartmentalize and try to stereotype diseases. Yeah, I know. Your whole life you learned that you're not supposed to have stereotypes. Well, in science and medicine, it actually helps you. Because when you know a bucket that you can possibly put this in, you might be able to quickly be able to diagnose and get to an answer. Now you also have to think, if nothing measures up, how do I think outside the bucket? Maybe this one doesn't behave like everybody else. Okay? So you don't want to be stuck with the stereotypes in science and medicine, but they actually do help you. And so this activity of writing a disease down and figuring out where does it show up, or what other systems would I look at to see if I can see evidence of problems, can be very, very helpful. Okay, we're going to look at a disease here in a moment as we wrap up today. But what I want to talk about are the 4 aspects of pathology. Number 1, we have etiology. Etiology is the study of causation or origination, where it came from. It comes from the Greek meaning to give a reason for. To give a reason for. Sometimes when we go back to the original Greek or back to the original Latin, it gives us clues as to what this word is all about. So etiology is the causation or the origination. Pathogenesis. This is the mechanism by which the disease is caused. The mechanism by which the disease is caused. Maybe it's a mutation at the level of DNA, and now the cell is replicating out of control. That would be the mechanism for what disease? Cancer. Very good. Okay? Morphological alterations. This is the 3rd aspect or feature of pathology. You've got the causation, the origination, etiology. You have the mechanism by which it happened, the pathogenesis. Patho-beginning, beginning of the pathology, right? Thirdly, you're going to have changes, morphological alterations in structure, both at the gross level as well as the microscopic level. That's one of the reasons for the DVD, is when we look at pathological tissues under a microscope, if you don't know what the normal tissue looks like, how do you know if it's different? So being able to compare and contrast normal integument, or what normal skin looks like, and you went through that in 201, you actually looked at the architecture of skin very, very elegantly. And then you compare it to skin cancer, you're going to see these microscopic differences. Now you're going to diagnose it macroscopically because it might be, well, that is a brown dot that's really gotten big, and it's very awkwardly shaped. It doesn't look like a round mole anymore. And I'm pretty sure like a year ago it wasn't even there. So that's a gross observation. Then you go into the pathologist, or you go into the dermatologist, and they look at it and say, this looks suspicious. I want to take a biopsy. They take a punch, they send it to the pathologist, they look at it, comes back and say, yep, that's a melanoma. Okay? We need to go in and surgically make sure we remove everything. Okay? So you're going to see gross as well as microscopic differences. And then last, but definitely not least, is the clinical significance. This is the who cares. So this is one of the reasons I think pathology is really kind of cool, is you have all 4 of these things that will show up all semester. And in every disease that we talk about, we're probably going to walk through elements of all of them, or a vast majority of all of them. We will always talk about the clinical significance, the translation, or the who cares. Why is it important? Because that's really what matters to the patient at the end of the day. And if you're their healthcare provider, or if you're the scientist that's trying to solve that problem, that's what is going to drive you to continue to do that type of research. It also is what those funding agencies are going to ask for. Now the funding agencies, all of them, ask for not necessarily the clinical significance, but what is the significance of the research. And if you write down there, just so I could be smarter, you're not going to get any money. Okay? So you're not going to be able to do research unless you have a really impressive who cares statement or significance. In this class, it's a clinical significance. All right, so I want to walk through one of our first diseases of the semester. And this flickering projector is really annoying. I apologize for that. And we'll try to make sure we get it fixed prior to next week. The first one we're going to dive straight into it today, Barrett Esophagus. Barrett Esophagus. Now, Barrett Esophagus is a disease that obviously targets the esophageal lining. And there's 4 main aspects of the disease. And it looks like I might need some new markers for this semester. So the first aspect that we're going to write here is what we call GERD. G-E-R-D. So GERD stands for gastroesophageal reflux disease. So patients who suffer from Barrett esophagus, which was named after the discoverer, is the name, usually have had persistent, untreated esophageal reflux, heartburn, gastroesophageal reflux disease. So, right, there's a upper esophageal sphincter and there's a lower esophageal sphincter. And when that lower one, that is the sphincter muscle that keeps the digestive juices in what organ? The stomach, from entering into the esophageal lining. When that sphincter is weak, then that reflux comes backwards up the esophagus, and that lining is not equipped to handle that hydrochloric acid, and so you get the burning sensation. Okay? So this is one of the aspects, is that these patients have GERD. Number 2 is about 10% of these GERD patients develop Barrett. Only 10%. So that 90% of the patients that present with gastroesophageal reflux disease never develop Barrett esophagus. And that's a good thing. Number 3 is, of these 10%, all of them, all 100%, have chronic GERD. Okay, chronic GERD, meaning that it's not like they've had heartburn for like 6 months. It's like they've had heartburn for like 5 years, 10 years, 20 years. Your entire life that you've known them. Grandpa's had GERD, or Dad's had GERD. And the way that they treat is they take a Tums every time they eat, after they eat dinner. Okay? And usually what ends up happening after this lecture is 1 or 2 students make a phone call. And they say, Dad, you need to go get that looked at. Okay? That's what happens. That's what happens with this class. That's why I love this class, because you guys, it's like hook, line, and sinker. You're into it because you know people that have these things. Right? And so you're motivated to study it. And that's going to make you that much better as professionals. Okay, number 4 is when the hydrochloric acid from the stomach is coming up the esophagus, the esophageal epithelium looks very different than the stomach lining. In the stomach lining, as you know, what was specialized about the stomach lining that allows it to handle that harsh chemical environment? What's that? What's that? What type of epithelium's there? And what features are in that columnar epithelium? You have goblet cells. Remember the goblet cells? And what do the goblet cells do? They release a mucus that lines that lining. You guys remember this? So this is actually 2 semesters worth of material, right? This is going way back to 201, where he talked about tissues, and this is going into 202, where he talked about the intestinal lining. So now what we see is what we call cellular metaplasia in these patients. And you're going to get into these terms next week in more detail. But cellular metaplasia, this is a word from the Greek that means change in form. Like, did you ever hear the word metamorphosis? Like in high school grammar or high school literature, where you're talking about metamorphosis. I think there was even a book I had to read called that. Is that a book? That was like a real thing, wasn't it? It's not like a bad dream, huh? That was a real thing. So, changing form. That's what this word means. And so now you have what we call cellular metaplasia, which is reversible. It's a reversible change in the cellular type because it's trying to behave the way the environment is telling it to behave. So I'm going to show you some examples of this metaplasia here in a second. But what I want to do is further flesh out the details of Barrett esophagus. So chronic GERD, and now this hydrochloric acid is causing cellular injury. And so the cells get damaged, and they're getting damaged over a 5, 10, 15, 20-year period. We already said that 10% of it develop Barrett from GERD. We don't know really why. It's only 10%. It just is. It seems like maybe the other 90% have mechanisms in place to be able to prevent the change in architecture of the cell. It's a risk factor, though, for those 10% of what we call esophageal adenocarcinoma. Right? Here's your first big word of the semester. Esophageal adenocarcinoma. If you don't know how to spell it, just write really fast, and then nobody questions you. Esophageal adenocarcinoma. So this would be what would happen if the cellular metaplasia was allowed to continue. So why is that? What's happening there? Well, at the level of epithelium, if you remember back to 201 in tissues, the epithelium has a stem progenitor layer. Right? And in the skin, do you remember what that layer was called? Basali, that's correct, and there was a word in front of it. Stratum basali layer, very nicely done. The stratum basali layer was the deepest layer of the epidermis that was the layer that was the regenerative layer that would turn over and give rise to all the superficial layers of the skin. The basement layer of the esophagus behaves in much the same way, and that's the turnover layer, right? And so the esophagus turns over on a regular basis its tissue, just like your skin sloughs off. You slough off your alimentary canal lining as well. Okay? So that stem cell layer, if it's experiencing hydrochloric acid or a harsh environment, it's going to start to change the type of cell that it produces. It's a stem cell, so it has what we call plasticity to become something else. And in research, it's kind of cool because we've actually started playing with stem cells in laboratories now. And we do this in my lab, where we take the stem cells out of the body and we turn them into something else. And now you can actually fix heart defects, or you can actually repair wounds. But in the skin, the stem cell, if it's given a signal that says this environment is more like the stomach, well then the stem cell is going to say, I'm going to start making stomach lining in the esophagus. That's called cellular metaplasia. Change in form. Okay? So we have three main types of stem cells. Now let's just review them really fast. The first one is considered embryonic. Right? And they come from the embryo. So we can't get embryonic stem cells from you and I anymore because we're no longer embryos. Okay? Number two is what we call adult-derived. Adult-derived stem cells. This is the one that you hear mostly being used clinically. We'll talk more about all this stem cell work later in the semester. I'm just introducing it right now just for the sake of completeness. Embryonic is the one that's most controversial. This is the one that you see most clinically used. And then the last one are what we call induced pluripotent stem cells, IPS cells. And the IPS cells, these are non-embryonic cells. They're adult-derived or from non-embryonic origins. But then what we do is we induce them backwards to trick them into thinking they are behaving like an embryo. And this is kind of the newest area of research right now, is this induced pluripotent stem cells. Okay, so if we look at the stem cells, what type of stem cell are we talking about in a patient? Let's say it's a 40-year-old male who's had chronic, unmanaged, untreated GERD, gastroesophageal reflux disease, for 15 years. Okay, since they're 25 years old, they started developing heartburn, right? And they just thought it was, maybe I just eaten too much pizza. Okay, but it never got better, and by the time they were 40, it's becoming more of an issue, and they're feeling a lot more uncomfortable. Okay, so what type of stem cells are we dealing with now in that patient? Adult-derived. Okay, so there is the ability for cellular metaplasia, and there's the ability to reverse back, but not nearly as powerful as if it was embryonic. Make sense? That's why we bring that up. Now, if I look at grossly, and this is where one of the features of pathology comes in, this is a scope down the esophagus in this 40-year-old patient. Why am I picking on the 40-year-olds? Because that's when everything starts going downhill, man. Stuff stops working, it just kidding. But it tends to be a really common area of when these diseases show up. 40 years old. Okay, so this one, I got to look at my notes here. So what we've got here is two different views down an esophagus. And the left image is the area of mucosal epithelium that's considered normal, this left image. Okay? So this white, glistening color is all normal. Well, why is that considered normal in the esophagus? Why would you believe that there would be sort of a whitish, glistening top layer in the esophagus? What's going on in the esophagus? What type of tissue is normally there? What is it? No, it's stratified, is correct. Stratified what? Squamous. Why? What's happening in the esophagus every time you eat and swallow? Physical abrasion, right? Food's going down the tube. Okay? Just like physical abrasion on your arms, right? Or your legs as you're wearing shorts and you run into stuff, okay? Or you're wearing pants and they're chafing against your leg. There's a pseudostratified or a stratified squamous epithelium in the esophagus, and that gives it this glistening white appearance. So the best way to describe that from a growth standpoint is if you have calluses on your hands or your feet, and if you look at the calluses carefully, they kind of look whitish and thick, right? Because that's that stratified corneum that's actually increasing in thickness and is giving you that appearance. Well, in the esophagus, it's just moist. Okay? Over here is a really black picture. That's really bad. That's really bad. It's not good. Over here. Oh, that's better. So here you can see the absence of healthy, stratified, moist squamous epithelium in a Barrett esophagus patient. Now, if we look a little further at this patient, right? This is a different patient, but this would be the morphologic progression. Now you have what we call cellular metaplasia, and you have a growth in the esophagus. This is an esophageal adenocarcinoma. And that's a sort of precancerous nodule that's discoverable. So two different pictures, right? You've got normal on the left. You scope the patient with an endoscope. You say, you know what? I don't see any massive lesions like here, but something's definitely happening. Okay, we need to manage your esophageal reflux. Otherwise, this could be problematic in the near future. And this is what it will lead to. Okay? So that's grossly. Now let's look at the microscopic level. Because I told you, one of the aspects of pathology, we're talking about how does it start, which we just told you, it's all GERD. What's the mechanism? Hydrochloric acid coming up. What's the macroscopic changes that are taking place, the gross changes? First stage is this. Later stage is an esophageal adenocarcinoma. What's the microscopic changes? Now you got to get out a biopsy. You take a microscope. You look at the tissue. Okay, and this is an image that's showing green means good, right? Red means bad. Green means go. So you can see this is stratified epithelium right here. Over here, do you see where my red laser pointer is here? Do you see it right here? What are these cells that I'm pointing at in the esophagus? Those are goblet cells. So if you told this patient, I'm seeing this, I'm going to take a biopsy, I get the biopsy back, and you know what? I took a biopsy sample of that adenocarcinoma, and it is not good. We definitely have changes happening to your tissue that are not normal. It doesn't look normal. I need to get it all out, and then we need to stop what's causing the cells to change from a stratified squamous to a pseudostratified columnar epithelium that actually has goblet cells, protecting itself from the hydrochloric acid. Make sense? So this is what's going on. So now the last piece of this example that we were talking about is what's the who cares? What's the clinical significance? Right? That's the fourth aspect of this particular example. Well, I told you everything's downhill at 40, so it starts at 40. Okay? It's usually 40 to 60-year-olds, usually white males. So you are going to start seeing aspects of epidemiology filter into this semester because you're classifying patients. You're going to look at ethnic groups. Certain ethnic groups are more susceptible to certain diseases. That is the study of disease. That's epidemiology. If you're looking at cancer rates in white males or Hispanics, okay, or black females, you're looking at specific classifications of ethnic groups because you're trying to track disease progression. You're looking at Native American groups with type 2 diabetes or multiple sclerosis rates of Northern Europeans. Okay, that seems to be the highest, actually, Northern Europeans. Like up in the Scandinavian area where they don't get a whole lot of sunlight. Localized ulceration. You just saw a picture of one. If it's greater, this is how you classify, if it's greater than 3 centimeters of Barrett type of mucosa, like what we saw in the pictures, then the patient is 30 to 40 times higher risk category of developing this esophageal adenocarcinoma. So that's where they get these numbers from. They say, I looked at this picture, okay, it looks pretty localized. It's precancerous for sure. It's only measuring about 1 centimeter. So it's about 1/3 the size where we start worrying about being really cancerous. Make sense? But let's get it out and let's get you something other than Tums. How many Tums are you taking? Well, like half a bottle every day. Well, we should probably get you something better. Okay, that actually is going to help with the sphincter activity and not just coat the esophagus. Now the problem is if you do not treat, this can advance to what we call dysplasia, and dysplasia is much closer to cancer. Dysplasia is a Greek word that means difficulty. And it's a term used to refer to abnormal development or growth. A dysplasia. So not is it just changing form with metaplasia, now it's an abnormal growth and you're one step closer to cancer. And that's not a good thing. Okay? Now, how would you take a look at other areas? And you can see in this picture this endoscope that would come in, and you can actually look at tissue in the stomach as well as the esophagus. So this is an EGD, right? This is a esophagastroduodenoscopy. Say that fast 5 times. Okay? And you can get into the esophagus, into the stomach, or into the duodenum, or the duodenum, right? Depending if it's potato or potato for you. And you can scope this tissue, which would be the end of that term, this tissue, which is the middle of that term, or this tissue, which is the proximal portion of that And you can see you can have a light that gives you the pictures with a camera. And then you can actually punch a biopsy, which gives you the microscopy that we just looked at. And that's how you do it. So patient gets scope. How do you get the scope down there? They basically swallow the scope, essentially. Okay?
That's what I was wondering. I was like, how do you open up the sphincters?
Yeah, they swallow the scope and they just advance it down. And they kind of wiggle it through. Okay? And usually the patient has a really aggressive sore throat after it's over. Like it feels like you had a strep throat kind of thing. All right, let's look at some other examples as we wrap up today. Okay? I'm trying to just get you primed for next week. So this is off of the DVD. So this is a way that you could use the DVD. Again, this is optional. You don't have to buy it because I'll show you stuff in the slides and lecture. But if you wanted to look at more images off the DVD, they're going to look, this was taken exactly from there. So you see normal tissue on the far left. And this is stomach-duodenum interface. Okay? So we're, with this endoscope, we're down at the stomach to where the duodenum begins, and we're looking at gastric emptying. And what you can see is, here's the lumen down here. Just imagine it. Close your eyes and picture what it looks like. That's what it looks like. And this is the tissue, and you can see there's evidence of immune tissue known as Peyer's patches. In an ulcerated peptic ulcer, you can see a lack of Peyer's patches. So the normal architecture is gone. And you can see this is all inflamed tissue. All of these additional purple dots are all new inflammatory cells that have migrated into the area as a result of that ulceration. So this is a classic example of how you would say, if I took a biopsy of the ulcer and I compared it to normal tissue, this is definitely pathological tissue. And this is what we're going to be doing a lot throughout the semester, is comparing and contrasting normal versus pathology. Okay? So we just did 2 examples today. We did normal esophagus, and we did Barrett esophagus. And I just kind of ended with normal stomach duodenal epithelium, and then ulcerated epithelium. And that's just an introduction to what we're going to be doing all semester and how we're going to do it. We're going to walk through the presentation. We're going to look at causation, the mechanism of how it occurred, what the pathology is, what macroscopic problems there are that you can see grossly, what microscopic changes you can see using a microscope. And then we're going to look at what's the significance, what's the result clinically. So, any questions from today? I have office hours today. I'll be there. Again, I got to end at 5:20 so I can get to the dance studio. And next week is when things really start. So take a look at the first lecture, and remember you have a pre-quiz due next Wednesday by noon. Okay? Have a great weekend. It seems weird to say that on Wednesday.